basic life support training for our health workers. Yeah, here we are this early morning. We were not able to deliver yesterday, but we had to make it a pretty hospital. We wish that you give him your undivided attention, then we move on as earlier.
Greetings everyone, my name is Hamid Samuezi, Anesthesia Department, Mujoko Hospital, and I'm glad to be presenting this to you even remotely. Today we'll be talking about basic life support, and I hope by the time we all leave here we'll have a thing or two to take home in that regard. Yes, so what's basic life support? Well, the definition is in the term itself. Basic life support is just a sequence of procedures done to restore saturation of oxygenated blood following sudden respiratory or circulatory collapse. So think of it in a way that you're just restoring the movement of oxygenated blood throughout the body to maintain the vital organs working. So basic life support in my discussion will not include the use of drugs or the use of other invasive skills to maintain saturation and respiration. Yes, so yeah, just briefly, the global burden of this is such that over 700,000 cardiac arrests are happening per annum, and over 60% of those can be reversed with just basic life support. So think of it as every 10 arrests happening around, you can reverse 6 of them with properly done basic life support without even getting advanced at it. Yes, so basic life support can be provided by a trained medical practitioner. Those do it very well, thank God. It can also be done by paramedics. These trained people we find in ambulances and other critical care centers. It can also be done by bystanders. That's the beauty of basic life support. It can be done by bystanders. You could be walking past someone who collapses and falls. You can do basic life support, and we just did 6 of the 10 patients happening to have cardiac or respiratory arrest. Yes, so why should we do basic life support for anyone? Yes, so we do it to maintain saturation and oxygenation. That's basic. It maintains the cardiac output and keeps vitals alive. So in cardiac arrests, we have the heart stop working. With basic life support, you're doing the pumping of blood for the heart. So that is why we are doing it. And then while doing that, we maintain the vitals alive. So we do it for cardiac arrest, if that wasn't already evident. We also do it for respiratory arrest, so even when you have a heart working and that's not breathing, you do CPR or basic life support, or even both, which is mostly the case. Yes, so when or how do we do it exactly? So there are actions for how to do it, and first we start by assessing for scene safety, as we'll see later. We determine for responsiveness, which has a specific way of doing it too. We shout for help, which is not as obvious as it may seem. It's a bit obvious to shout for help when you, as an instinct, when you need help and you shout for help, but it's a bit difficult to shout for help as a step of resuscitation because it has to be done very well and very clearly. So you check for carotid pulse. Check for the carotid pulse and perform chest compressions immediately if you lack the carotid pulse. Yes, then you open your airway and then start breathing for the patient later on. Yeah, so while doing basic life support, we follow a CAP-D approach as opposed to the ABCD approach. And by that, we do the compressions first before we take care of our airway and then go to the breathing. Well, the D is for the defibrillation if needed. Yeah. Okay, so how do you assess for scene safety? So you make sure the scene is safe for you to start with, because there will be no BLS if there is no you doing the BLS. So you make sure if it's in a house full of smoke, maybe there's a fire somewhere and the patient has collapsed, you don't start your BLS there. You take the patient away. It's no point doing basic life support for a patient who is under the table because you can't work. And then you make sure that the scene isn't of further harm to the patient. If a patient is, still in harm, there's no point in trying to resuscitate them. You're not helping anyone. Yeah. So assessing for responsiveness, as I said, it has a unique way of doing it, and by that you shake at the shoulders while calling out aloud to the person, are you okay? Or are you alright? That is easy to say right now, but instinctively you'll find people just shouting the person's name while slapping them square in the face or shaking their heads. That is catastrophic sometimes, because if a person has got a neck injury, you'll find yourself having snapped their neck before you start resuscitating them, and that's not so much life support there. At the same time, while you're shaking at their shoulders, you're looking at the torso and the chest for any movements. They may not be able to say, I'm alright or anything, but while shaking at their shoulders, you'll see them respond, like if they're breathing or having any saturation going on. So how do you assess for saturation? You assess for saturation by palpating at the carotid pulse for 5 to 10 seconds, nothing more than that. If you need more than that, then you're not doing a good job, you just start your CPR. Or you just don't have a pulse, there's no point in looking for it any further. And if there's no pulse or there's abnormal breathing while at it, you shout for help and start CPR. So you'll notice that I didn't put shout for help on another point here, because there's no time that should be spent shouting for help. You don't need 2 seconds to shout for help. You need to start CPR immediately after these 5 to 10 seconds. Any time beyond that and you're doing your patient a disservice or making your work a lot harder. Yes. So how do we do CPR in this kind of person? So you place the patient's spine on a hard, flat surface. So spine is lying flat on their back, and you make sure they are on a hard, flat surface, so they're not on a moving bed. They are probably down on the ground, because that's where most people fall to anyways. So you kneel down to the patient and locate the lower third of the sternum. So the lower third of the sternum usually is at the nipple line, so you don't need a lot of seconds doing that. You lie down the patient at the nipple line. In the middle of their chest is where you lock your arms with the heel of one hand over the other hand. And your elbows should be straight directly over the hands. So we shall see it just there. So as you may see her, she has locked the palm of one hand over the other hand. Her elbows are straight and she's not leaning backwards but directly over the person. So you see the shoulders, the elbows and the hands directly above each other. And the hands the eyes are looking straight at the chest and at the patient. She's likely to have a lot of assistance, but when you're alone, you may have to do all this yourself, and it's just basic, it shouldn't be very hard. Yes. So use the upper body to push down, not just the arms. So she doesn't push with her arms, she pushes with her upper body, and you aim for a 5 to 6 centimeters compression. So this may be simple to think of it like that, but think of a compression which is equivalent to two joints in your first digit, in your first finger or index finger, and that is the depth of your compressions you need to make. If you do it properly, you'll even surprise yourself or worry that you may crack the patient's chest, but a few ribs cracked is better than a dead patient, so you better do it properly. Yes. So what is the chain of survival, or the things that should be done properly if you're going to have any successful basic life support being done? One, you must recognize it very early and call for help. So immediately it happens, you do not need time to first take selfies or record a YouTube video to post around, show someone having fallen somewhere. Recognize it early and call for help. So you do this and then you start early CPR. Early CPR helps you to buy more time, because the earlier the CPR, the more the chances of survival for that patient. And then, if you can, you'll do early defibrillation as soon as your help brings you the defibrillation. You'll do it early, and then for proper survival, the proper survival also entails post-resuscitation care. So after the patient has been resuscitated, they need that care, otherwise they will not survive much longer. Yes. So if we're talking about CPR, it has to be quality CPR. Not just every CPR is worth of basic life support. So what describes quality CPR? First, it is the frequency of the compressions. They should be hard, they should be fast, and they should be equal. So when doing compressions, while you're counting, people always make the mistake of having compression number 10 faster than or harder than compression number 1. So they go 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. You know, that kind of thing. People always have that. So they should all be equal. They should be and fast. Yes. So allow for full chest recoil. So as you're doing your 5 centimeters, you take off your hands and let the patient's chest recoil back to the normal before you do the next one. So while you allow for maximum chest recoil, you must not allow for any inconvenience or interruptions to your compressions. And then you must have 30 compressions initially at a rate of 100 to 120 per minute. That's the rate. So the quality CPR has got 4 components: the rate, the quality of the compressions, and then allow chest recoil and do not allow for interruptions. Simply. Yes. So that was for the compressions. How about for your airway? So for the initial compressions, assess and establish the proper airway. So the initial compression we spoke of was the 1 cycle of 30, and after doing that, or while you're doing, after doing that, if you are alone, you assess for your airway then to make sure it is proper. How do you do that? If it is not, you open the airway, and there are 2 ways of opening the airway. One is the head tilt and chin lift maneuver, as you can see her trying to do there. She like tilts the head downwards and lifts the chin. That's the easiest and the simplest for everyone to do. However, we have also got a jaw thrust maneuver where she's supposed to lift the jaw, the lower jaw off of the upper jaw, which can be a bit more complicated, but that always gets the work done, the head tilt and the chin lift. Yes, so after doing that, you give 2 rescue breaths. So each rescue breath should be lasting at least 1 second while you assess for visible chest rise. It's pointless to give a rescue breath when there is no chest rise, you're doing nothing, probably giving it into the stomach or something. Yes, so 1 cycle, just to take home, 1 cycle is 30 compressions and 2 breaths. Yes, and you must perform 5 cycles of CPR, approximately 2 minutes, and switch roles if 2 or more providers are available. So you call for help, someone has probably come. So you can't be compressing the chest all the time, you'll fatigue early. Yeah. So continue to resuscitate until you get qualified help, or until the victim starts breathing normally. Just breathing is not enough, they should be breathing normally, or until the rescuer becomes exhausted, because there's no point of having 2 people need resuscitation, both the patient and the rescuer. Yes, so after doing all that, if you have an automated external defibrillator, now would be a good time to use it. And why an automated one as opposed to a manual one? Well, automated ones are more available. Automated ones will pace for you. Automated ones will tell you when to shock, and you do not need a lot of training for them. So an automated one is one that is recommended for basic life support. Advanced life support, we'll talk about any others. But the device is with the ability to detect irregular heart rhythm and to automatically deliver a defibrillation shock that will result in return of the normal rhythm. So it will do all the work for you. All you need to do is press 1 or 2 buttons and you'll get the work done. So it's designed to be used by even passers-by and lay persons. So complications of CPR, after we've done all that, what do we expect our patient probably to have if we overdo it? So we expect if we overdo it, as I said, we may get a rib fracture or internal organ injury if we overdo it. Vomiting and aspiration is something we can expect as a complication, or gastric distension because of the breaths we are giving if we're not doing them well. Instead of giving them into the airway, we'll fill the stomach, and that's what they call gastric distension. Yes, so post-resuscitation care. This is very crucial for anyone in case you've returned a person back to spontaneous breathing and saturation. That is just half the journey or half the fight won. You still have a lot of work you need to do, for which includes the post-resuscitation care. If you do not do it well, the patient will return back into the arrest mode and will have a lot of work left to do. So what do we do after the patient has returned or we have resuscitated our patient? We need to optimize them hemodynamically. We need to do respiratory and neurologic support. Just because they're breathing now doesn't mean they'll keep breathing for the next 5 minutes. You have to support them and support their airway. So identify and treat for reversible causes of arrest. Now, I will not go through the reversible causes of arrest. Probably in another talk we'll talk about them. But then we have various H's and T's as acronyms for the reversible causes of cardiac arrests. So you have to identify what caused the arrest in this case and treat it. Otherwise, if you don't, as soon as you stop, they will arrest again and it will be harder to resuscitate them later. So you monitor temperature and consider treatment of any disturbances in temperature and metabolism regulation. Now, this is one of the single most crucial steps in post-resuscitation care. If I were to assess all these, if you could only do this, temperature and regulation of metabolism, you couldn't do all these others, you would have done half your work for post-resuscitation care. So this is why you need to take a patient to a more specialized unit and have them admitted in a critical care unit, probably an HDU at least, or an ICU if we have the facilities for that. Yeah. Thank you very much. Again, I'm Hamid Semwezi, and again, please stay tuned and subscribe to our channel, as our next session will be a more practical approach to basic life support, where we'll be talking about actually how to do the CPR, how to position yourself, and how to do all those steps. It is more crucial to have the practical aspect than just the theoretical bit of it, because as you'll understand later, it's one thing to know something in your head and it's another thing to do it without having to panic. So please stay tuned.